Hi, welcome to YP Speaks. My name is Jordan Jarvis. I'm the Executive Director of the Young Professionals Chronic Disease Network. And we host YP Speaks on a regular basis to hear from our members from across the world about different issues related to non-communicable diseases and work that they're currently undertaking to help us learn a little bit more about different aspects of the global challenge of non-communicable diseases and understand it better. And so we're very excited today to have Dr. David Watkins with us from the University of Washington, although currently in Cape Town. So David Watkins is a clinical instructor in the Department of Medicine at the University of Washington. He's worked on cardiovascular diseases in Africa since 2008 and is a research associate at the University of Cape Town. His research focuses on health systems around cardiovascular diseases in low resource settings, and Dr. Watkins is also a research fellow with the Disease Control Priorities Network, and he's a contributor to several NCD-related reviews and analyses for the upcoming Disease Control Priorities on Developing Countries, 3rd edition. Originally from Tennessee, Dr. Watkins received a Bachelor of Science from Rhodes College and a Doctor of Medicine from Duke University. Before moving to Seattle, where he completed a residency in internal medicine and a master's in public health through the Institute for Health Metrics and Evaluation at the University of Washington. So welcome, David.
Thanks, Jordan, for having me. I'm glad to be here today and glad to share with you some of the work that I've been doing recently. This is a bit of a more technical talk, I think, rather than a sort of policy and advocacy talk, but I hope we can generate a bit of discussion as I present some of these new tools around economic evaluation for NCDs.
So one side note while you're pulling up the slides is for the viewers, we do have a question and answer box enabled. So please feel free to submit your questions to David over the question and answer box or submit your questions over Twitter. And we want to make sure that we continue a great discussion on this topic during the talk, but also thereafter, because this talk will be available over YouTube.
Great. Thanks. So the topic of my presentation today is going to be economic aspects of NCDs, looking through the lens of universal health coverage. And universal health coverage is a really hot topic right now, not just in NCDs, but across a wide variety of diseases. And I want to focus really on NCD-related aspects of UHC because NCDs are really, of course, growing part of global health, and they present special challenges for health financing in developing countries. I want to acknowledge that most of the work that I'm doing right now is for the Disease Control Priorities 3rd edition, and the real brainchild behind this is Dean Jamieson, who is the principal investigator, and the idea of extended cost effectiveness analysis that I'll be talking about is sort of Dean's idea, and much of the work is going to be presented in DCP 3. So you can look forward to more of this stuff then, and you can always go to the DCP3 website, the URL is below, to get more information on what's going on with the larger DCP effort. So I want to talk briefly about health systems and what implications those have for universal health coverage, some of the economic barriers specifically around NCDs, and really why different economic evaluation methods are needed, and then present some examples of extended cost effectiveness analysis and how it can be useful for NCDs in particular. And then I'll touch a bit on some of the lingering methodological and data-related issues that we're all facing with these new methods. So traditionally, cost effectiveness analysis was a tool for healthcare decision makers, primarily in wealthier countries, who were trying to decide what are the trade-offs between technologies, especially newer technologies. So for example, which breast cancer screening strategy provides the best value for the money? So in this study above, you see that there are strategies A, B, C, D, E, and F, and they all have a certain cost and a certain health benefit. So ranking those things and deciding which one provides the best value for the money, that's sort of a goal of traditional CEAs. And another question that's been more of interest recently is healthcare pharmaceutical prices have gone up is, well, a newer drug may be more effective for instance, hepatitis C, but is it worth the additional cost relative to the existing technologies? And so really, classical cost effectiveness analysis presents what are called incremental cost effectiveness ratios. In other words, how much additional money is required per additional unit of health bought. So dollars per death prevented or dollars per quality adjusted life year gained. Now, about 15 years ago, the WHO, Chris Murray and colleagues at WHO developed a series of tools extending the idea of cost effectiveness and generalizing the idea to look more at policies. And so they really began to think not so much in terms of incremental cost of certain interventions, but really what are the total costs and total benefits of doing a whole public health program. So for instance, this study that was published by Chris Murray and colleagues in The Lancet now 12 years ago, looked at a variety of interventions around hypertension and high cholesterol. And the methodology of WHO choice was that if we assume no interventions, no policies, nothing exists across a wide variety of diseases, which types of interventions are cost effective, which types can buy the most health per dollar spent. And so these results are often presented in terms of total cost versus total disability adjusted life years or whatever metric. And so it's an extension of the idea of cost effectiveness analysis more from a policy standpoint. But WHO choice application has been somewhat limited, and more recently, people have been thinking about things besides health that we want to buy in healthcare. And as we think about universal health coverage, this cube that's been shown in a lot of health systems and policy meetings sort of comes up very quickly. So if we think about the pathway to universal health coverage, you think about on the axis here that's on the lower axis between poor and rich, you think about coverage, proportion of the population covered. You think on the axis that extends from the front to the back of the screen, what proportion of cost are people paying out of pocket? If you think about what types of interventions are paid from the sort of the y-axis here, the y-axis of what interventions, in terms of cost effectiveness, are paid is really the only axis that's being covered by traditional CEAs and even the WHO choice methodology. So these two axes, the coverage axis that's the x-axis here and the out-of-pocket prepayment axis, it's the z-axis, are actually not even captured in traditional cost effectiveness analysis. And as you can see, if we're striving towards universal health coverage and sort of filling up this cube, we really need more metrics and more ways of assessing pathways to UHC. So this is where extended CEA comes in. So Dean says, people ask, what is the extended CEA about? ECEAs are actually about what health systems are about. So if you look at the WHO health systems framework and sort of the inputs, so the building blocks for health systems and the outputs, traditional CEAs look at just the overall level of health per dollar spent. But extended CEAs also look at the following metrics: health equity, so the distribution of health in the population, as well as financial risk protection. And financial risk protection I'll refer to as FRP just for short. FRP basically is the idea that when you pay for healthcare, if you pay a lot of your income out in terms of health expenditures, you may go into poverty or face catastrophic health expenses or have other adverse financial events. And so interventions that reduce the financial burden on the individual are said to have financial risk protection for the individual. So you can see where that cube actually comes in with these ECEA metrics. So you may ask, well, why do we care about FRP and equity, particularly around NCDs? Well, it turns out that a large burden of NCD economically, of NCDs is borne by individuals, so an out-of-pocket cost, because in contrast to most wealthy countries where insurance mechanisms, prepayment mechanisms are the way that health systems are financed. In many low-income countries, care is financed almost 100% out of pocket. And so this is a study by Mark Huffman and colleagues a few years ago, looking at across 4 countries, what proportion of patients with cardiovascular disease had catastrophic health expenditures or had to buy or sell or borrow or sell assets to actually pay for their health care. And so you can see it's quite a bit in countries like India and Tanzania. So why measure these things? Well, governments actually explicitly, through universal health coverage mechanisms, or implicitly, so through public health programs, buy financial risk protection by choosing to cover certain interventions. And they should also care about the distributional impacts of their policies. And so the question that ECEA answers then is, what types of policies buy the most financial risk protection and or the most equity for the amount of money invested? They also care about health benefits, but FRP and equity are additional metrics that are embedded within an extended CEA. So I'm going to share with you a few lessons we've learned from doing some of these ECEAs, and hopefully you'll see how they apply to NCDs and UHC. The first lesson is really looking at the insurance value of non-insurance mechanisms. So this was a study that I did looking at salt reduction in South Africa. So the South African government recently proposed a series of regulations, or implementing a series of regulations around salt reduction at the population level. And we found that there was basically about an 11% reduction in cardiovascular disease, or would be an 11% reduction in cardiovascular disease due to just reducing salt intake. And in fact, that also, besides reducing the risk of cardiovascular disease, also reduced the risk of having to pay for cardiovascular disease out of pocket. And so how that translates into private payments, out-of-pocket payments, is that about 2,400 cases of catastrophic health expenditures, or using a different metric, to about 2,000 cases of poverty a year could be avoided by reducing salt intake in the population. And essentially that's an extra insurance policy for the population that's has nothing to do with healthcare coverage and insurance coverage, but it also protects people financially from the adverse effects of cardiovascular disease. And so really these regulatory and other sorts of measures can provide additional insurance beyond what the government is able to do through fiscal measures alone. We also found that this actually saves the government a lot of money because the government's the major payer of cardiovascular care for the population. The second lesson from ECEAs, I think, is also really important for NCDs, because ECEAs, by looking at equity, are actually able to disentangle some of these issues around equity and NCDs, and particularly around regressiveness of taxation. So we all know that tobacco and alcohol taxes are really popular and really touted by public health people to be very effective, and they should be done everywhere. And yet, from an economic standpoint, taxes are tricky because they're inefficient, and they cause theoretically, a high tax on a low-income person can cause them to be financially burdened. And so people have been against tobacco taxation conceptually because, well, if the poor are paying a lot in taxes for cigarettes, they may be a health benefit, but it's a bad economic thing. It's regressive. So my colleague Stefan, who's now at Harvard, led the study looking at tobacco taxation in China and showed that basically, yes, there are some negative effects on the poor in terms of the price of cigarettes, but they're actually more price sensitive than wealthier smokers, and so they're more likely to quit. And so the health gains actually also go preferentially to poorer smokers. And it turns out that even if there's a small increase in tobacco expenditures in the short run, the probability that the smoker is going to quit if they're poor is much higher. And so in the long run, the reduction in health expenditures around cardiovascular disease and cancer and those sorts of things actually outweigh the negative economic impact of raising prices of cigarettes amongst the poor. So this is a very helpful tool for understanding how policies have an effect across different segments of the population, and really understanding whether policies are regressive or not. The third lesson, and probably the most exciting one for UHC in particular, is that actually when you begin to include FRP, or financial risk protection, as a metric, when you plot it against the health gains that policies can buy, you can really get a sense for what diseases do what sorts of things in the population. So Stefan again led this up, and I was part of this study looking at public finance of healthcare interventions in Ethiopia. So on the right in this graph, you see vaccinations, diarrhea treatment, malaria, C-section. Down at the bottom is hypertension treatment. So this study looked at what if the government spent $100,000 on each of these treatments, assuming a certain level of coverage. Well, it turns out that financing reproductive, maternal, and child health interventions actually tends to buy the most health per dollar. And so down in this lower right quadrant, you see vaccinations. The number of deaths averted per $100,000 spent covering vaccines is substantial. And yet financing adult health interventions actually buys the most financial risk protection per dollar. So this is these interventions up here in the upper left quadrant, where you see that they're not necessarily averting a lot of deaths, but they're averting a lot of poverty cases, because these are the diseases that are expensive, and they're diseases that affect working age adults who are actually providing incomes for their households. And so you can see for the same amount of money spent on various interventions, how you have a trade-off or a tension between interventions that promote health, interventions that prevent poverty. So this actually is a really useful tool for thinking about UHC, because UHC really tries to maximize both of these things, or at least find the point of indifference where that dotted line is, given certain budgetary constraints, and find which interventions are actually more likely to promote, financial risk protection and or health gains. And so this is a really, really useful tool, I think, for those of us working in NCDs, because NCDs are diseases that, that the interventions we have are not as effective as child health interventions. They're not as perhaps attractive from a fiscal standpoint. And yet, if we're thinking about economic development, if we're thinking about equity, the interventions that we focus on with NCDs have a lot to do with overall economic well-being of adults in developing countries. So having said all these things, there are a few lingering issues. First of all, ECEA results are kind of hard to generalize and compare between settings, because really they're contingent on local health system structure. So what effects you might have around SALT in South Africa would maybe be different in Argentina, or a country that has a higher proportion of a lower amount of out-of-pocket payments around cardiovascular disease. There's very little empirical data on how NCD care is financed in low-income countries. So we know a bit about out-of-pocket payments in Africa, but we don't really know a lot about healthcare seeking behavior, about demand for healthcare, about how individuals choose to, or how much individuals have to pay for certain types of care for certain NCDs in a lot of countries. And so there are a lot of assumptions, unfortunately, that go into some of these models. And we have these metrics such as catastrophic health expenditures in poverty cases, but maybe there are other metrics that matter. So, selling assets or borrowing money, maybe that's also important to people. So we're trying to think of other ways of thinking about financial risk protection and other metrics that might be meaningful to policymakers. Having said that, poverty cases averted resonates very, very clearly with a lot of policymakers, and so we're sticking with that for now. The final issue is not really a UHC thing, but more just a cost effectiveness thing, which is that there are still ethical intentions inherent in this. So, especially for NCDs, we talk about scaling up cheap preventative things like reducing SALT, reducing smoking by taxing people, versus actually paying for people's healthcare, paying for dialysis or heart bypass surgery. And so there's a tension between prevention and treatment ethically when there's a limited budget. And so those tensions still exist even with extended CEAs. So those are really kind of more value judgments that governments have to make in terms of how they're going to spend resources. You can say that there's a certain amount of equity or financial risk protection from paying for heart bypass surgery and a certain amount from reducing SALT. But really that point of indecision is more of an ethical issue that's not really covered by these economic evaluations. Having said that, hope you can get a flavor of what extended CEA is about, and as this conversation around UHC moves forward, hopefully you'll see more of these extended CEAs and maybe even participate in some yourself. So that concludes the sort of formal part of my talk, but I'm happy to answer questions and refer you to other papers if you're interested.
Great, thanks very much, David. That was a great overview, and it was really interesting to hear about these studies that you presented. And so I'll just encourage at this point any of our viewers to please submit questions to the question and answer box for David, and we can get a discussion going. In the meantime, I'm wondering, you just mentioned this ethical tension between prevention and treatment. And I'd love to talk a little bit more about that. Do you think that there's a need for more open discussion on this tension at the global stage? And how can we, get this discussion going if it hasn't necessarily been covered enough?
Yeah, I think it's a good point. I guess just talking about the ethics issues is something I've thought about a bit. I'm obviously not an ethicist, but really, I think part of the issue with NCDs comes from the fact that we think of these things as preventable, but the prevention capability between NCDs actually varies quite a bit. So for instance, another disease I work a lot on is rheumatic heart disease. Rheumatic heart disease is almost completely preventable with something that's pretty cheap, like penicillin. It's also pretty expensive to treat with, you usually need heart valve surgery in adulthood if you have rheumatic heart disease. And so there's a tension there. It's very preventable. By contrast to something like obesity or hypertension, those things we have interventions, but they're not exactly 100% effective. And the treatments are also expensive. So between NCDs, and then you get into things like mental health as well, you think about the preventability aspect versus the treatment aspect. I think it varies a lot between diseases. And so there's not a real good sense for whether we should be focusing on prevention versus treatment. As a primary care oriented person, I like to think that we can prevent stuff. But I think that when we think about ethics, we think about the HIV/AIDS movement. There's been most of what people get excited about. Most people, what gets people to protest, gets people to be active, to be activist, is actually getting people on treatment who need treatment, who are dying now. And so, empirically, when you talk to people in society, most people tend to prefer harm alleviation versus harm prevention. So there's sort of a principle of compassion, this idea of duty to care, and healthcare providers especially feel this. Where we see a patient in front of us suffering, we may say, this person needs surgery right now, and that's more important than talking about abstractly preventing disease in the future. And also, if you're kind of close to the suffering and it's very vivid to you, like we tend to gravitate towards those things, even if they're sort of less cost effective. And at the same time, there's sort of a consequentialist or utilitarian streak within a lot of people in policy where they say, well, we're trying to maximize health. We need to try to find the ways to overall get the most health for our money. And if that happens more through prevention strategies, we should do that. So for instance, for rheumatic heart disease, you may get a lot more health benefit in the population by focusing on prevention, so getting penicillin out. Even if you're saying, well, we don't really have capacity to offer heart surgery to people in a very low resource setting. And that may actually be a government-based budget, a rational, an economically sound judgment. And yet you're sort of left thinking, we think we're doing the right thing, but it comes from a certain bias, a certain utilitarian sort of bias. And I don't think that the jury's out on this, because really a lot of it has to do with ethical biases or ethical sort of presuppositions that are larger in a sense than these studies, than these economic analyses. So yeah, I think that it's an important debate to have, and I think that ultimately, at the end of the day, it's a value judgment that should definitely come from country, right, from decision makers, and from people in the country itself, rather than from on high. And certainly, it's an ongoing debate.
Yeah, definitely. It's one that we've engaged in, and I mean, just thinking about a somewhat disproportionate focus on treatment and the NCD movement over the past few years. I mean, still a lack of funding for both prevention and treatment, and for NCDs in general and global health. But certainly, I think it's starting to be more of, that the treatment discussion is picking up a little bit, in the recognition that we do need to treat the people who are suffering or living with NCDs right now, and we can't just focus on prevention.
That's right. That's right. Yeah. And I think that when you think about global development assistance and all the money that's spent on HIV/AIDS and those sorts of diseases, and the fact is, by comparison, NCDs get relatively little of the pie. I think that actually is a conscious choice by a lot of funders. For instance, the Gates Foundation, they're focused on improving the health amongst those who are worst off. And so it's a conscious choice by a lot of donors to say, we recognize that we could probably do something that's more economically sound, but we actually are really explicitly making an equity choice here. And so it may feel like we could maybe do something a little bit better, more efficiently. And certainly I'm not arguing that that's the right way to do things. But it goes to show you that in societies, we have these sorts of explicit judgments that we make that don't necessarily maximize, the economically maximize the outcomes. And so, I think that for NCDs, we have to just be aware of the issues and be aware of the fact that we want to advocate for the people that we know are suffering, especially children with NCDs. We want to do these things. The distribution of resources globally and the amount of resources that's in the public sector for treating and preventing NCDs is just low all around. And so you kind of weigh between being an advocate and then also saying, well, from a very utilitarian standpoint, how can we do the most with the money that we do have?
Yeah. And I mean, that's where I think studies like you've done in South Africa and Ethiopia are important to help governments understand some of the economic benefits that can come from tackling these issues. But I'm wondering how much, you think governments still need to be convinced of, adding taxes for tobacco control and even food regulation or marketing. And I mean, I guess, what is the research that we still need to do in that regard, and also in investing in treatment?
Sure. I think that for a lot of these more population level interventions, there are political factors that are really country specific. So for instance, in South Africa, this SALT story came about because the government wanted to do this and they felt like it was the right thing to do. And they actually got the industry around the table, and industry said, we want to be part of this discussion. We want these to be mandatory regulations and not voluntary. We want the playing field to be level. And so in this particular context, this worked out in this way. Whereas in other countries, different nuances come about. So in the UK, they had a lot more trouble with SALT regulation. It was a more voluntary sort of thing. And so in every context is different. So the story around tobacco taxation is similar. In China, doing tobacco taxation is fraught with a lot of political complications because the Chinese government is involved in the tobacco industry. And so you can make a lot of these sort of arguments for the economic benefit, and yet there's all these external factors that are really influencing decision making. So in any given country, a package of NCD interventions is going to be received very differently, and that's where having a really good relationship with country partners and really have a lot of advocates on the ground in many countries is important, and that's why YP is, I think, so important. Where a lot of the YP members who are in country are doing so much great work.
Yeah, great. And I mean, we definitely always want to hear from people like you who are doing research to see how we can translate some of the research and the evidence and bring it to policymakers and show how the policy implications and the changes that can happen, and then make sure that these are actually implemented. And I guess one point in relation to that is that thinking about national essential medicines lists.
Mm-hmm.
And so what, maybe for those who don't know, so the World Health Organization has a model list of essential medicines that guides country selection of what are deemed essential medicines to prioritize the key medicines that should be available to all within the country. And so countries are responsible for prioritizing their own list of essential medicines that they want to be available to their people based on their resources as well as the burden of disease. And so one issue that we've seen in some of our, in the advocacy and looking into how national essential medicines lists are used is also, I mean, a lack sometimes of the implementation and of tying it to reimbursement schemes and coverage. And so I wonder if you've thought about that and how, in terms of, the policies and how to tie it more to less out-of-pocket spending.
Sure. Yeah, I think that actually the Ethiopia study that I presented probably is the best model for that, because essentially that the methods that were presented actually have a direct application for purchasing essential medicines or choosing which ones are purchased and covered under a public sector formulary or scheme. And so you could think about, for instance, a package of medicines for high blood pressure, for diabetes, et cetera, that are generic, that are effective, that are useful for a variety of conditions. Pick your favorite beta blocker, for instance, and your favorite ACE inhibitor. And you could say, well, if we spend a certain amount of money on purchasing, setting up a supply chain, purchasing a certain amount of these medicines, and then rolling out to district hospitals and the dispensaries, et cetera, what kind of impact will that have on the population in terms of health, but also in terms of preventing people from having to pay for those medicines out of pocket themselves or not taking them at all because they can't afford them? So that's sort of what this extended CEA actually tries to assess as well. If you actually start prepaying for certain essential medicines, what impact will that have on poverty? What impact will that have on the demand for NCD care? What impact will that have on people choosing to receive preventative care? So preventative in this case being treated for high blood pressure rather than going to hospital for stroke. And so you can begin to model those sorts of effects much more easily than you could just with a traditional cost effectiveness analysis. So I think that actually, when we think about essential medicines and we think about the choices governments make around which medicines to cover, then thinking about a package of NCD-related medications that are likely to be very useful for health, but also likely to be equitable too, likely to be by a high degree of financial risk protection. I think those are questions we can begin to answer with extended CEA. Certainly there's a lot of data needs, like, I think supply of medicines in many countries in the world, there are very few studies looking at barriers to supply of NCD medications. One from WHO in 2007 that I'm thinking of now, but there's just not a lot of literature on what medicines are available in what countries and what are the major constraints. But there are supply chains for other medicines that that exist and they're well established. And so I think that part of this also stands outside of just the economic evaluation and more an implementation science angle too.
Yeah, great. Well, I think this has been really useful, and I've learned a lot during your talk, and I hope that others will also contribute any questions going forward and discussion on the aspects that we spoke about today. So at this point, I guess we'll just wrap it up. We have our half an hour of YP Speaks that just we've gone through. So thanks so much, David, for your time and for sharing your work with us.
Great, thanks for having me.
Bye.